frequently asked questions about endometriosis. What is endometriosis? It is the presence of endometrial tissue outside of the uterine cavity. What are the types of endometriosis? There are generally three distinct clinical presentations: endometrial implantation superficially on the peritoneum, endometrial-lined ovarian cysts, chocolate cysts, or endometriomas, and endometriotic nodules, a complex, solid mass of endometrial, adipose, and fibromuscular tissue found between the rectum and vagina. What are the risk factors for endometriosis? Early menarche. First degree relative with endometriosis. Late menopause. Low body mass index. Mullerian anomalies. Nulliparity. Prolonged menstruation, more than 5 days. Shorter lactation intervals. Shorter menstrual cycles, less than 28 days. What is the clinical presentation? The clinical presentation of endometriosis is highly variable and ranges from debilitating pelvic pain and infertility to no symptoms. Many women with endometriosis present with non-specific symptoms, such as chronic lower back pain or abdominal pain, which may delay diagnosis. What are the physical findings? Similarly, objective physical examination findings are limited and non-specific. Although many women with endometriosis will have normal examination findings, some will exhibit tenderness of the posterior fornix, limited motion of the uterus or ovaries, or an adnexal mass. Some women will have diffuse tenderness on pelvic examination. However, in women undergoing evaluation for infertility, uterosacral nodularity with associated tenderness is pathognomonic for endometriosis. How is the diagnosis established? The diagnosis of endometriosis in primary care is initially clinical and based on history and physical examination findings. Histologic confirmation is usually achieved with the detection of extrauterine endometrial cells on laparoscopy. Less invasive diagnostic tests are being pursued. Transvaginal ultrasonography can reliably detect cystic endometriomas, 89% sensitivity, 91% specificity, and is considered the imaging modality of choice. What is the treatment? Initial treatment includes common agents used for primary dysmenorrhea, such as non-steroidal anti-inflammatory drugs, combination estrogen, progestin contraceptives, or progestin-only contraceptives. There is some evidence that these agents are helpful and have few adverse effects. What if NSAIDs and oral contraceptives are ineffective? If NSAIDs and hormonal contraceptives are ineffective, the next step is treatment with a GnRH analog such as luprolide or goserelin. GnRH analog therapy downregulates the pituitary, resulting in medical menopause, and has been shown to improve pain in women with endometriosis. However, the therapy causes adverse effects, such as hot flashes, night sweats, and possible bone loss, in many women. To mitigate the menopausal symptoms, reinitiating hormone therapy with low-dose estrogen and progestin is common. Danazol, an androgen, is effective in the treatment of pelvic pain associated with endometriosis. However, androgenic adverse effects, such as acne, hirsutism, and male pattern baldness, often limit its use. The drug has several U.S. Food and Drug Administration boxed warnings, including the risk of thrombosis and teratogenicity. What are the surgical options? Laparoscopic ablation of deposits and excision of endometriomas are options to relieve pain and treat infertility. Excision of endometriomas will more effectively improve pregnancy rates than a drainage and ablation technique, but there is little evidence on the success of surgical treatment in advanced disease. If a woman with endometriosis does not desire future pregnancy and all medical treatments and conservative surgical therapies have been ineffective, a hysterectomy may be performed. When is referral to a gynecologist necessary? Referral to a gynecologist is necessary if symptoms persist or the patient is unable to become pregnant. Women with infertility due to endometriosis usually will undergo laparoscopy. In women with mild endometriosis diagnosed by laparoscopy, surgical treatment of lesions improves pregnancy rates compared with no treatment of lesions.
Audio Jungle. Audio Jungle.